Hello, everyone. I'd like to thank the editorial board for giving us the opportunity to present our phase 1 trial on arterial embolization with hypoxia-activated tirapazamine, TPZ, for unresectable HCC. Currently, transarterial chemoembolization is the recommended treatment for intermediate stage HCC. However, it is palliative because recurrences inevitably occur, and hypoxia is supposed to play a big role. So what if we replace the standard chemo and TACE with an agent that's activated in hypoxia, such as TPZ, leveraging its mechanism of failure? We conducted a phase 1 multicenter open-label non-randomized trial with a 3+3 dose escalation design and an expansion cohort in patients with unresectable HCC, child Pugh A, ECOG 0 or 1. The primary objective was to evaluate the safety of the combination, and the secondary objective was to determine optimal dose for phase 2. The first two cohorts, TPZ was administered intravenously at 5 or 10 milligrams per meter square. Those were done at the request of the FDA. The TPZ was administered systemically once the catheter was in position superselectively. Immediately after the administration, embolization with gel foam and Lepidol slurry was performed. In the remaining 3 cohorts, as well as the expansion cohorts, the catheter was positioned superselectively, and TPZ was given intraarterially locally at 5, 10, or 20 milligrams per meter square. The expansion cohort was performed at the last dose. This was followed again immediately by embolization with gel foam and Lepidol. If there were multiple lesions, the TPZ was divided according to the volume of the lesions. If there were multiple feeders, the tumor volume supplied by each artery was used to determine the amount of TPZ injected in each of the supplying vessels. The adverse events and serious adverse events were determined according to CTCAE version 4. There were clinical imaging, laboratory, and PK analysis, as well as EKGs 1 day before, at 1, 2, 4, 6, 10, 24 hours post-TPZ infusion. There were also additional PKs at 15 and 30 minutes post-infusion. The patients were seen in clinic at 1, 2, 3 weeks after the procedure, and then every 6 weeks after that for the first year, every 3 months following. Tumor response was evaluated by mRECIST. 27 patients with a median age of 66 were enrolled. Their mean tumor size was 6.5, and the median number of lesions per patient was 2. These are their UNOS-T stages. Cirrhosis and portal hypertension was present in 59% of patients, and all patients were deemed unresectable by multidisciplinary tumor board. The most common adverse events were related to post-embolization syndrome. None of the serious adverse events were drug-related. There were no dose-limiting toxicities, and the maximum tolerated dose was not reached. 60% achieved complete response, and 84% achieved either complete or partial response per mRECIST for the target lesions, and the duration of response was not reached. In summary, the phase 1 trial showed that TATE, or transarterial tirapazamine embolization, is feasible and safe, and the preliminary response is very encouraging, warranting a phase 2 trial. Thank you.